Okay. Now, as you must have realized that we've been talking about acid-tolerant bacteria and acid-labile bacteria. And of course, if you know the pH of the stomach is about like 2, so it's more of an acidic because of hydrochloric acid. And this is a typical mucosa, as you can see from here, the gastric mucosa. So we have this layer on top of that for protective layer. We already discussed that in detail as a part of gastrointestinal physiology, how the acid is produced. And what are the control mechanisms? And as usual, I'm going to give you a little bit of historical perspective of what we are going to discuss today. Gastric ulcer has been known to exist for quite a long time. And there was no association with gastric ulcer with the bacteria till one of the physicians in Australia noticed that what he did was he had post-mortem specimens of those people who died of gastric ulcer, and he wanted to grow a bacteria from there. And he did, and that was helicobacter pylori, and he presented his research in medical conferences, but nobody would believe him because there was a very strong lobby. People used to think that there is no role of bacteria there. So, as I said the other day, it takes a while for scientific community to accept a fact. It's always a hypothesis based upon logical reasoning. And then it must have taken him at least 10 years to prove his point that yes, gastritis is related to helicobacter pylori, and he was able to show that. And when they found out, I think a couple of years ago, they had to give him a Nobel Prize for that. So you can see that Nobel Prize in medicine is a big achievement of one of the major concepts in the medicine when you want to relate something of that nature. And of course, for a good purpose, one of the best-selling drug for a while has been, even now, is a proton pump inhibitor, PPIs. And then again, everybody goes through a gastritis phase of gastritis. There are many causes for that, but that was the first attempt to relate it to bacteria. And those of you who are interested, I think there's a very good presentation on nobelprize.org probably of his presentation when he presented that his work in that meeting. But anyway, Helicobacter pylori, as you can see, this is how it looks like. And of course, it's going to be an acid-tolerant bacteria and one of the culprits of gastric ulcer. So now the standard treatment of gastric ulcer is that we do culture this bacteria from aspirate or after gastroscopy. And then there are quite a few other tests available for the metabolic activity of this bacteria. And we do give antibiotics for that to make sure that we get rid of this bacteria. And you can see from the sites where this bacteria is located. And I'm not going to go back and explain to you the immune response. But you can see from here, you just have to combine your information that you learned in gastrointestinal physiology with immune response. And you can see over here there's a mucus layer, and then helicobacter gets into the submucosa, and we have an acute inflammatory response with all the cells of acute immune response and even chronic immune response, especially Th1 type cells are there. And antigen presentation is taking place, and then these antigens are presented, and then we have a robust Th1 type of response in gastric mucosa, and you see all these kind of hyperinflammatory condition in gastric mucosa. So the other important thing for this particular bacteria is in terms of pathogenesis, in terms of immune response, that we see quite a few patients who are asymptomatic, but they have chronic gastritis. And since there's a presentation of the antigens for that particular bacteria to antigen-presenting cells, and you can see dendritic cells over here. So we develop autoantibodies, which are very specific for some of the enzymes which are there. So that's another important thing we have to keep in mind. And recently, the work has shown that those particular patients who have chronic gastritis may have low regulatory T cell count. So that's another important thing, because I don't need to go back and explain to you what is the role of Tregs in a typical acute or chronic inflammatory response. But this is something that is there, especially for one of the, as I said, one of the commonest problem we have in the world, gastritis, and one of the best-selling drugs which are available in the market, like proton pump inhibitors. And before that, it used to be histamine blockers, Tagamet and Zantac, and all that kind of stuff. Okay, so let's talk about a little bit of microbiology of Helicobacter pylori. And again, we'll go through the same 5-6 basic objectives for each and every bacteria. These are gram-negative rods, as we already said, and they appear to be a little bit curved. The important thing that I'm going to tell you, and again, for those of you who are making those concept maps and charts, I'm going to talk about 3 bacteria today, so you can start putting them into different tables so you know what's the difference between these 3. One of the most important things that you have to keep in mind is when we talk of helicobacters per se, that there are 2 types of helicobacters. One of them are gastric helicobacters, like Helicobacter pylori, and there are some other which are uncommon. We call them intestinal helicobacter. The important thing is that they produce urease. The urease production at a very high level is a typical of gastric Helicobacter. So what is going to tell us that we can come up with a test to look at a metabolic byproduct of a bacteria, to design a test whereby we don't have to culture the bacteria, but we can go and look for, like we talked about, fermenting lactose fermenters in terms of Enterobacteriaceae. So in this case, urease production will be used as one of the most important tests that we have currently. If any of you or any of the patient goes to be tested for gastritis and especially Helicobacter pylori. As far as pathogenesis factor or virulence factors are concerned, like any other bacteria, it has to be acid tolerant, otherwise it will die. And then again, it's going to cause colonization, inflammation, and it will alter gastric acid production and tissue destruction. So that's the most important thing. Today, what we see in clinical practice is that, of course, historically, it was related with gastric ulcer. I told about the Australian physician who was awarded a Nobel Prize for that. But now we know that Helicobacter pylori is an important cause of both acute and chronic gastritis. It's also cause of peptic ulcers. And the story doesn't stop here. And I'll just want you to take you back a little bit with the pathophysiology that we discussed in the later part of physiology, that chronic inflammatory conditions can lead to cancer. So this is one of those conditions that you cannot take it lightly, because there is a high incidence of gastric adenocarcinoma in those patients who have gastritis, especially associated with Helicobacter pylori. So this is one of the very common questions asked, that we know for viruses, we talk of HPV, that's associated with cervical cancer, but for bacteria, this is one of the most important bacteria that is listed as a cause of adenocarcinoma. Not only that, it's also associated with mucosa, associated lymphatic tissue, MALT, mucosa associated lymphatic tissue lymphoma. So there's another kind of a tumor associated with that. So that happens when bacteria. That's why we want to go in a little bit of detail. Who's doing Helicobacter pylori in this class? Who has this individual project, Helicobacter pylori? Okay. There you go. All right. So this is a very common question asked, that one of the bacteria is associated. If you look at a electron micrograph of that, it shows multiple sheets over here. It shows unipolar flagella. So you can see long flagella. And of course, if you know the function of flagella is just to allow the bacteria to swim, to go and move in mucus. So it's going to go and penetrate. So it's like that kind of motion that's there. If you look at the scanning electron micrograph, again, this is basically a technique that we use in our lab as well. It's called magnetic bead isolation. And you can see we can isolate these bacteria. Sometimes they appear as bacilli, sometimes they appear as coccoid. So that's again a pleomorphic kind of a picture that you can see in a culture. So you have a culture, you have to grow them for a long time, and these are electronic beads that we have. If you to look at the section of gastric mucosa, there's a very special strain, Warden starry silver stain, and this is a typical of that. And I did post, some of the slides there for your practice as well, because some of the slides may be included in exam for you to identify bacteria in that particular slide. Okay, so that's, I think, a question like fill in the blank. You have to write it up, the name. So you can see from here a typical crest over there, like an ulcer, and then you will see a H. pylori there. Okay, there are some factors related to the food consumption of people, but again, remember, I'm pretty sure that Dr. Mukherjee is talking about that. When we talk of the numbers, when we talk of percentages, things are not simple. It's not like an election thing, percentage of votes. So the stat is how you present the data. But all you need to know is that it is common, and it's been shown in low socioeconomic class people. Probably they tend to ignore going to the doctor, or they don't even know that it's associated with a bacteria. And humans are the primary reservoir. Person-to-person spread is important. Fecal-oral route, they're present everywhere, all over the world, because one of the commonest symptoms as a humans we have is when you are tense, you have disease, under stress, your stomach gets inflamed. It's as simple as that. That's acute gastritis. That's what we call out the burning pain. So burning pain it could be because of the inflammation of esophagus or gastric mucosa. That's what we call heartburn. It's nothing. Heart doesn't burn, but stomach burns. That's what it is. But it's located over there. That's why we say heartburn. Okay. Now, again, the important thing for this bacteria is, like many other bacteria, it has the ability to establish lifelong colonization in the stomach. So if you have it and you've been having gastritis over time, it's going to stay there. It's not going to go anywhere. Okay, but I wouldn't call that as a commensal. There's no commensal of stomach. The commensals are usually for the skin and mucous membrane, right? But for stomach, we don't normally say commensal. We do talk about commensal for intestinal, but we normally do not, right? Because of the acid nature, number one. Number two is that we still are not sure that how many bacteria are there, because we are unable to demonstrate presence of bacteria. As I just told you, like 30, 40 years, there was no mention of Helicobacter pylori. Not that it did not exist, because we didn't have no means of culturing it. So our lack of having methods to culture this bacteria suggests that we don't know. It shows like our ignorance. Now, why do they colonize gastric mucosa? Because they are tolerant of the acid. They're going to go and alter gastric acid production, and they will cause tissue destruction. But the most important thing that you need to know that in terms of immunology, in terms of pathogenesis of immune response, is that the very first initial colonization, for example, you didn't have it like age 30, and all of a sudden age 31, you have colonization of this bacteria. So what happens is blockage of acid production by bacterial acid inhibitory protein. So bacteria releases a protein which is acid inhibitory protein. So it, before it goes over there, it prepares the room, so to speak, right? So it's want to release a protein, it's going to inhibit. Right? So even if it's acid tolerant, it's going to make sure. And also remember, many times we learn and we pick up these proteins from bacteria and use it for our purpose, because we figure out, because it's like the bacteria is teaching us. So we can purify that acid inhibitory protein and use it, okay? The second thing it does is that it neutralizes gastric acids by ammonia. So it secretes ammonia, right? And how does it secrete ammonia? Because it has urease activity. So if you know the reaction of urea and ammonia conversion, so this is what the bacteria do. And as I said earlier, that once this takes place, because ammonia is, you can smell, it's just like alcoholic. So you can smell alcohol, you can smell acid. So if you see these, I mean, it's one of the orders that is there for these people, and we use that as a gadget to test the presence of Helicobacter. This is like, alcohol test by the policeman or what have. Exactly the same thing we do in terms of looking at ammonia levels as a test for the urease activity of this particular bacteria. That's a standard test today. We already talked about that they are highly active because they have flagella. They pass through the gastric mucous membrane, and then again, they have multiple surface adhesion proteins. And some of these proteins not only bind to epithelium, they also have the bacteria to evade immune detection. So these are some of the fight put up by the bacteria. That's what pathogenesis is. What is the fight put up by the bacteria, and what is our immune system doing to counteract that? And whosoever wins. Mostly, if you have disease, this is a bacteria that wins. Okay, now for the tissue destruction that we see in this, the question now in terms of pathogenesis will be, how does this bacteria cause ulcer? So ulcer is a damage to the tissue. Tissue is very well protected because we use that tissue daily, right? It's there. It doesn't have autodigestion. So whatever you eat is still going to go into the stomach. But what bacteria does is that it releases urease, and then the byproduct of these are these mucinase, phospholipases, and the most important thing is they have vacuolating cytotoxin. So it also releases a toxin. And remember, I would kind of give you a little bit of update to make sure you understand the mechanism of toxins, especially differences between exotoxin and endotoxin, and where they are located, because that's the weapons that these bacteria have. So this is especially a protein that once they are endocytosed, they basically change the cells by producing vacuoles. So it is going to, some bacteria will poke holes there, some will attach to those receptor proteins. So this is something that goes into the cell and then make holes there, we call vacuoles. So this is what the potential for gastric ulcer is. The other important thing for this particular virulence factor bacteria is a cytotoxin-associated gene, COG-A. So that's again a gene which may have many other genes. You don't have to remember, but I think what I want you to do to at least remember. If I was to ask you how does, and I'm pretty sure it's going to be repeated over and over again as well, how is gastric ulcer caused? And it's an acute inflammatory response. I don't want to teach you what the cells of acute inflammatory response are, what are the cytokines of each Th1 response is. But you do remember that when we talked about some of the chemotactic cytokines that are released in the tissue that will attract neutrophils. And one of those cytokines were IL-8. So this particular gene protein is going to act as a chemotactic factor and will bring in neutrophils. Your own cells are going to destroy your gastric cells. That's why you see a lot of neutrophils over there. Okay. It also has release of proteases and reactive oxygen molecules for the neutrophil. So what happens is the neutrophils are there to be protective, but if they're too much over there and you burst them open, so they have all those reactive oxygen species that are going to cause tissue damage. So all those things that they have within themselves of tissue digestion are going to be used against you, and bacteria will just initiate because of that specific protein released by that and then cause tissue damage. Okay, so how do we diagnose that? I already told you that most of the time when you go for a complaint like heartburn and it's for there for a long time, they will want to put a tube in your stomach and see for yourself where is it coming from. So one of the things they would do in that, they will also take a biopsy and then test for it if there is a helicobacter. But the most sensitive and highly specific test is urea breath test. It's like, I just gave an example for alcohol test. So they're going to make you respire into that machine. And then if you have Helicobacter pylori, they are producing ammonia. So you will have this urea breath test, we call urease test. We can also look for the antigen test, which is also very sensitive. But this has to be performed in stool specimen. So that's another thing. So you can look at the tissue specimen, you can look at the breath test, and you can look at the antigen test. If you were to look for the culture, the problem is that you have to have microaerophilic conditions because it doesn't like much of oxygen, a little bit of oxygen, and the growth is very slow, and it's difficult to culture, to be honest. And we also look for H. pylori serology because I just told you that it makes autoantibodies. So autoantibodies, especially against the acid-producing kind of enzymes, ATPases, so that's important. So we also look for, because one of the mechanisms could be there that your autoantibodies are also playing a role in terms of digestion, in terms of causing gastric ulcer. Now the question is, how do we treat it? Again, before you treat, you want to demonstrate whether it's there or not. Okay, so what you need to do is that once you found that, so today we give combined therapy, we give proton pump inhibitor like omeprazole, and then we give a macrolide, clarithromycin, and we also give a beta-lactam amoxicillin for 2 weeks, and it does have a high success rate. So that's like out there, but the most important thing that you have to make sure that you don't have those conditions. I just told you about autoantibodies. I told you about some of the exotoxin. I told you some of the vacuole-forming things within the cell that may lead to adenocarcinoma, especially of the lower esophagus. So that's also important for us to make sure that once you are looking for gastric ulcer, things are not simple. It shouldn't be taken lightly because it's associated with a cancer. We are working on vaccines, but currently not available. So that's like research in progress. Okay. In the same kind of sequence, like helicobacter, we have campylobacter. And many a time, like for example, I said Helicobacter pylori, which is a part of the stomach, pylorus. But I told you mostly that it talk of gastric ulcer. And I told you the cancer it causes, what type of cancer does it cause? I just told you like a second ago. Huh? Well, that's a tumor of adenocarcinoma. You're right. Of what? Lower esophagus. Lower esophagus. So keep that in mind. Sometimes the words are a little bit misleading. It's called Helicobacter pylori. It should have pyloric end, but it causes gastric ulcer. But it can cause gastric adenocarcinoma as well. But the commonest that we see is lower end esophagus. So this is where some of the distractors will be added when you're asked the questions. So you have to a little bit pay attention to that, okay? Now, by the same token, we have Campylobacter jejuni, as the name suggests, it may be in jejunum, but again, if you look under the microscope, you will see that they are thin, curved, and gram-negative. So this is like a gram-negative bacteria. You can see over here. These are the ones, okay? Then again, for every bacteria, remember, they have a pathogenic factor. And for every pathogenic factor, they have to colonize, they have to adhere, they have to penetrate, they have to release something to cause damage. That's what we need to know. That's what pathogenesis means. And how does our immune system take it, okay? So in this case, they can adhere, they are mortal, and invasion into our poor, but we're still working on it. That's why I tell you that they are there, and we are still working on finding out factors which are there for adhesion, right? Because as I said, prevention is more, primary prevention is more protection in terms of treatment. So we don't want them to adhere there. So that's the major thing. The difference between Campylobacter and Helicobacter is that one had adenocarcinoma, but this one has a Guillain-Barré syndrome. So it causes Guillain-Barré syndrome. This is one of those bacteria that is associated with an autoimmune disease. And no wonder why, because we talked about that earlier, that some of these bacteria can evoke a response in terms of autoantibodies. Okay? And I don't intend to explain to you the mechanism of autoimmunity. You pretty much know what is there. So the reason is that there's a cross-reactivity between the oligosaccharides, the bacterial capsule, with the glycosphingolipids of the surface of neural tissues. So you make an antibody against a particular part of that bacteria, right? ABC, for example. But these ABC are also present in your neural tissue. So if the antibodies are going to go and kill that bacteria, they're going to be attached to your neuronal tissue and cause damage in your brain as well. That's autoimmunity. That's called cross-reactivity. Okay? The presentation is acute enteritis as compared to acute and chronic gastritis for the previous one. So you can make a note as we speak. Okay? And it's presented with diarrhea, malaise, abdominal pain. Most infections are cell-limited, but they can last for a long time. The most important of the Campylobacter series is one of the Campylobacter is called Campylobacter fetus. And this one is associated with septicemia, and this is disseminated to multiple organs. So of all the different types that this particular family has, the most dangerous, which is called septicemia, Helicobacter doesn't cause septicemia. Septicemia means that you have sepsis, you have what you call bacteremia. And not only bacteremia will be just presence of bacteria in the blood, but this is sepsis as shock. So that's the difference between these two. Now, what is a zoonotic infection? We talk about that in the journal Bacteriology as well. Do you have a test on Friday? Or Friday, 8 a.m.? Yeah. Well, not only it can be transferred from the animal, it is an infection of the animals. Zoonotic. Zoo. From zoo, I told you, zoo. How many of you understand English? Okay, I may have to change the language. It's such a Google language thingy. I said zoo. She's right, but that process is a different process. When I say zoonotic, means primary infection of the animals. Okay? And of course, there are birds and every whatever is there in the zoo. But if they are transferable, that's what we are discussing here. Otherwise, I wouldn't have talked about it. I'm not teaching you veterinary microbiology. It's a little bit different. Oh, not a little bit different, because I was reading an article yesterday. Those of you who have plenty of time like myself, that one of the killer whales becomes sick in, I think in San Diego. And now the weight of that killer whale is 12,000 pounds. So you can imagine how much antibiotic they're going to give it to that animal if you calculate per weight. It's a lot. I mean, things are different in zoonotic diseases, but they pretty much have the same thing that we have. Anyway, why do we get this particular disease? Again, is contaminated food, unpasteurized milk, or contaminated water. Person-to-person spread is unusual as compared to the previous one, which was common. Okay. Now, this one requires a dose which is high. So what it's trying to tell is that, I'm just going to throw an arbitrary number, that if one bacteria needs 100 bacteria to cause a problem. Okay? So they will wait till they achieve that 100 bacteria. It's usually more than that. I'm just giving an example. Okay, but what you can do is that you can help them. You can help bacteria. How do you help them? What you do is that you take antacids. You take antacids, so you remove the acid from your gastric mucosa, so you will lower the dose. Because most of them got killed because of acid, right? And you are neutral. That's why chronic use of antacid is a problem. So it's a patient education. Everybody, and I'm pretty sure everybody, you'll have heartburn for 4 years being a pharmacy student. It's normal. But you don't take antacids every day. You want to take omeprazole every day, unless you've been diagnosed. And you understand the point? Because you open a window for many other bacteria by giving them an exemption to go for a lower number of causing disease. Okay. Worldwide distribution is there throughout the year. Who's presenting this individual project? Okay. Make sure that you give us the WHO statistics for that. What is the incidence world over? Okay. How do you diagnose that? Because all this epidemiology thing, I'm trying to use it as give you the textbook thing, and sometimes I use the new figures, but I would want you to give me the new figures in terms of the current CDC and WHO statistic for some of the important diseases. So they are gram-positive. They are present in the stool, but the method is not good enough to pick it up. Again, they have a requirement that you have to grow them into specialized media, and you have to incubate them for 2 or more days. Normally what we do is that we look for the campylobacter antigens in the stools. So that's good enough for us, because sometimes thermophilic means that these are those species that like to grow in higher temperature. That's what it means. Okay. Now, if patient presents with gastroenteritis, and all you need to do for most of the gastroenteritis treatment is you just want to manage fluid and electrolyte balance. It's self-limiting. But if it's very severe and have septicemia, we want to treat with erythromycin or azithromycin. Azithromycin. So these are the 2 important things in terms of treatment. And we can, of course, make sure that we don't take uncooked or partially cooked food, and we consume pasteurized milk And again, water supplies have to be regulated by the government. And I think those I posted this yesterday as well. When you look at the enterococci thing, in that lecture I do talk about the permissible levels of bacteria in normal consumption of water. So there is a level of bacteria. There's no such a level. There's no absolute no. But again, there are something permissible level, and some of the bacteria they want to go and look for in terms of their presence at a particular level. And lastly, we had the two earlier were more of a microaerophilic. They need a little bit of an oxygen. That's why, or some of them have a little bit of air there in terms of the tract. But bacteroides is also a gram-negative bacteria as anaerobic, right? Now the question that usually are asked is, for example, which one of the following is anaerobic gram-positive? And which of the following is an anaerobic gram-negative? So make sure now that you know which is anaerobic positive and anaerobic negative. It doesn't say over here, but that's what the distractors are going to be. Okay, because they are more important in terms of our knowledge. And I'm not going to ask you which one is gram-positive, anaerobic gram-positive, because you know it, right? Okay. The reason is that when we have a wound, especially a huge wound for roadside accidents, operations, and so, there's a lot of tissue death. And tissue death means lack of oxygen. So that gives a breeding ground, a culture for these bacteria to grow, especially Bacteroides fragilis, you can see, and other microbes, other anaerobes. Sometimes of this kind of infection that we normally see is polymicrobial. So we teach you bacteria separately. It doesn't mean that you will see one case with one infection. You may not. So you may see polymicrobial, more than one. But then again, we have to culture it. But this is a typical case when a person had a very small infection that started over here in the scrotum, very small little kind of infection over here, and from scrotum it spread all the way up. So you can imagine the extent of damage a tiny little scratch, a tiny little injury on scrotum can do to the rest of the body, especially when you deal with Bacteroides fragilis in terms of tissue damage. So that's why you really have to make sure that you properly diagnose it and probably treat it ASAP. Of different kind of bacteroides, there are many different types of bacteroides. One of the most common that we see is fragilis. It's most important. It comes in different size and shape, and you see that different size and shape and structures under a gram stain. So you wonder, so far, most of the bacteria that I've been talking about, we talked about gram staining. So that's like a life-saving test to initiate the therapy, whether it's a gram positive or gram negative. That will make a lot of difference in terms of our treatment plan because of the extent of damage that these bacteria can do. If you're to look under, for example, microscope, you can see gram-negative rods, typical gram-negative rods, and pleomorphic. They are coming in different shapes, and that's a culture picture of the gram staining picture of Bacteroides fragilis. In the structure, the most important structure for, of course, gram-negative are more dangerous as gram-positive. They have a polysaccharide capsule, and the major part of that capsule is LPS. What does that suggest to you? Yeah, of course, that's what you say. But what does it suggest to you if I say it's LPS? Okay, so very sharp immune response, totally out of control immune response. As been saying over and over and over again, LPS is the most potent activator of immune system. Okay, and we talked of endotoxic shock. Okay. Anyway, so you can see if you look at these LPS molecules, because LPS molecules are different in many other. For example, if you were to look at fusobacterium, which is also a gram-negative, but it's aerobic, if you compare that with this one, then the LPS has little or no endotoxin activity, right? So what it's trying to tell you in this case is that depending upon the polysaccharide capsule, there's no such thing like LPS causing, let me put it this way, like same LPS in all the bacteria. Because of the differences in LPS structure, right? There was one very closely associated LPS. What was the name of that? In one of the bacteria, I said, make sure that you understand that. LOS, very good. Lipo-oligosaccharide, LOS. So remember, a little bit of differences that we have in terms of saccharides are going to change their immune response, okay? So you can see from here that if you compare that with the other LPS molecules, especially for aerobic gram-negative, so that's like a comparative study, we find there is little or no endotoxin activity. And the reason for that, again, is, and I'm not going to ask you this one, but it's all pure biochemistry in terms of the structure, and I will let pharmacology people take care of it. Because even in a LPS molecule, right, if you change the phosphate groups, right, so there are different phosphate groups. If there's a slight change in phosphate group, we still call it an LPS, but the response will be different. That makes sense? And that again explains to you that for example, some of the LPS will have a pyrogenic activity, so it will cause fever. Some of them would not. So that again will depend upon the sequence of those phosphate groups, especially glucosamine residues. So if you look at the structure, which I'm not teaching you right now, I just told you that you need to know 3 components of that, okay? And especially lipid A, that's what I told you, lipid A, that for micro purposes, that's what we call as endotoxin. But again, keep also in mind, there's no such thing as one, right? So there are different types of that based upon the structure element. That's why all LPS would not have a same immune response. That makes sense? So that's coming from, you can see the phosphate group or the glucosamine residue that will change the number of fatty acids. In the same way, remember when I was talking about the difference between nocardia and mycobacterium, I was telling you a very specific length of a acid, right? That will make the difference in terms of their effect. So that's where we look at the staining, and we also look at the treatment options that we have. Okay. Now, there are many different types of species, but luckily we have very few who cause disease. Most of the things that we see intra-abdominal infections are coming from B. fragilis. That is already there. So what normally happens is that if you do surgery, for example, and you open up the abdomen and you also cut intestine, so they're already sitting over there, they will come out of the intestine and come in peritoneum and cause intra-abdominal infection. We call it peritonitis, right? Or there's a stab wound that passes through the skin, punctures the intestine or colon. Again, it will allow those bacteria to come out and cause infections. So that's what's happening in terms of intra-abdominal infections for B. fragilis. The other virulence factors that this particular bacteria has is that they have these factors which can cause adherence to the tissues, and then again will avoid, same old story, those factors which are released, so you avoid host immune response and cause more tissue destruction. Okay. So when we talk of bacteroides, for example, one of the things that they have, especially when they adhere to cause, because they have a polysaccharide capsule that has adhesions, adhesion. They will attach to those epithelial cells, and those epithelial cells have what are the adhesion molecules which are normally present in epithelial cells? Selectin. Okay, very good. What else? Specifically for for bacteria. And you will, if you go back with whatever 12, 13 bacteria I've taught, I did mention at least 2 of them over there. Yeah, anybody? Louder. Say it again. What? Fembry? No. Well, as usual, many a time I ask you the question, the answer is already there. Fibrinogen, fibronectin, and lactoferrin, these are those important adhesive proteins that are already present on our cells. And what it needs is that they will attach to these one by the fimbriae, because my question, what was there on the epithelial cells? I know what's there in prefacet because they have fimbriae and they have this sticky thing, but what is it that holds them? So these are those proteins which are fibrinogen, fibronectin, and lactoferrin. So these are the important things that are jutting out of the cells and catching them up and allowing them to come in. Then again, they avoid phagocytosis because, like any encapsulated bacteria, they have a polysaccharide which is antiphagocytic. The other important thing is that they have a short chain fatty acid like succinic acid, which are produced during their metabolism that will also inhibit phagocytosis and intracellular killing. So these are 2 important anti-phagocytic mechanisms that are unique for this particular bacteria. There may be some other, like Mycobacterium has one of the phagosome-lysosome fusion inhibitor. But in this one, basically what is happening is, other than the capsule it has a short chain fatty acid, which is succinic acid, which is produced when they metabolize anaerobically and then inhibit phagocytosis. Let's say even if they are phagocytosed, because remember that why do we need to know that? Because they're causing too much tissue damage. So they also have tolerant exposure to oxygen. So what they do is that these particular bacteria produce 2 enzymes, catalase and superoxide dismutase. So these 2 will chew up the oxygen radicals. So if you throw oxygen radicals on them, right? So they have 2 enzymes, catalase and superoxide dismutase, that will kind of be protective and would not cause damage. Once they are phagocytosed, you need oxidative radical killing. So these are the reason that you saw this enormous slide that Dr. Murray showed you with too much tissue damage. And if you remember, starting from the scrotal injury all the way to the abdomen and even deeper. So it also has cytotoxic enzymes. And then again, they have other important things to cause tissue destruction. They can inactivate immunoglobulins. We talked about superoxide dismutase. So all these things are the pathogenic factors or virulence factors why this bacteria is causing so much of a tissue damage. Okay, and this will be unique for this bacteria. And in terms of toxin production, it produces a heat labile metalloprotease toxin. Can somebody tell me what is the significance of metalloproteins? What is a metalloprotein? Don't tell me it's a metallic protein. Okay, because we did discuss that as pathophysiology in physiology many years ago, right? Okay. So if you remember when I was talking about metalloproteases, I said these are scaffolding of the cell. So these are little metallic bars which will keep the cell as they are in the form and shape. So in this case, what is happening is that they release a toxin, which is enterotoxin, and that will chew that up. So it will change the actin rearrangement. So when you change the structure element, roof goes down, the floor goes up, so you cannot maintain the normal function. So what will happen is if you change that, you will cause the cells to release fluid. So fluid will leak out because of metalloproteases that we have in teas. The other important thing, like Helicobacter pylori, is that they have a toxin that you see IL-8 secretion. And what would IL-8 do? I just told you. What would IL-8 do if you release IL-8 into the tissue? Huh? Say it again. It causes tissue damage. What exactly is the function of IL-8? I just said. Chemokine for neutrophils. Good. Chemokine for neutrophils. I just said. So it's going to cause neutrophils to come over here and cause tissue damage. Very good. So this particular are anorgamid active. They pretty much are present everywhere, and I just told you that they are a common culprits when you open the abdomen, roadside accident, stab wound, and so on and so forth. So if they have such a list of causing damage, so of course the more virulent, the more pathogenic the bacteria is, the more infections you have. It can cause respiratory tract infection, brain abscess, intra-abdominal infection, gynecological infections, skin and soft tissue infection, so on and so forth. Because this bacteria is equipped with so many damaging things. Okay, so the more damaging thing it has, the more problem it's going to cause. And you can see, I'm just going to run through that. Liver abscess, you can see from here. We look at the tests to be pretty much the same. We look for most important biochemical test for this is these are resistant to kanamycin, vancomycin, and colistin. So if you were to grow them in agar, for example, if I was to grow them in agar, I have to add 20% bile. Right? And if you remember when we talked of bile in gastrointestinal tract, bile is released from the gallbladder and it acts on the the contents of intestine, right? But in this case, this loves to grow in bile. So that again, is something that will cause this to have a free access to those areas. This is a typical growth that you normally see in terms of bile being there as a part of that. In terms of treatment, again, we want to do antibiotic therapy, surgical intervention, because you have to remove the dead tissues. If you look at them, especially they have beta-lactamases, so all your penicillin will be redundant because we already talked about beta-lactamases. And in the final slide, what you need to do is that many times when you do operation of that nature, pre-operative, you want to give antibiotics if you feel that that's what we call that gut preparation. So if you want to make sure they open the gut, so you have to prepare the gut, basically remove all the bacteria over there, give antibiotics, and then go from there. Okay, so I'll stop here and take any question that